Welcome to the REX implant REX hands-on. First of all, we have to talk a little bit about the anatomy of the bone that we are using in this kind of procedure. We use the cow rib because it looks like a mandible. You can see this looks also the internobicular line. And now the most important thing is to establish the crestal width. And to do that, we're measuring with a periodontal probe. You can see that we have almost 3.5, 4 millimeter. The top of the ridge is almost 3.5, 4 millimeters, so it's fine. 4 millimeters is perfect because this hands-on is focused on the surgical protocol of the implant site preparation technique for perforation. And you have to remember that the thickness of the REX implant 1.8 is 1.8 millimeter. So we need to find at least 4 millimeter of crestal width in order to maintain at least 1 millimeter buccally, 1 millimeter lingually. Another important consideration is to establish the thickness of the cortical bone. We don't have any CTCB, of course, like when we perform live surgery in the patient. So now we can see in this osteotomy, and we can measure that the cortical crestal thickness is 2 millimeter, a little bit more than 2 millimeter. Another important consideration is the distance between the two cortical walls, the lingual one that usually is thicker compared to the buccal one. Of course, if you see in this area, the posterior area is thicker, and the medial area is thinner. Why is so important to establish the distance between one implant to the one cortical to the other? Because when we prepare the implant side, theoretically, it's more convenient to stay into the cancellous bone. If we make an axis not too wrong, maybe too lingual or too buccal, we engage the cortical, and cutting the cortical is definitely difficult than this. So now, another important characteristic is that usually the top of the ridge is curved, is not flat. So the first things that we have to do is to obtain flat surface. So now I fix the bone in a proper way, and then we start to obtain a flat surface in order to achieve 4 millimeter mesiodistally. To do that, I'm using one piezosurgery tips called SLC. I developed this tip for the sinus consuming technique. It's very effective because this flat border of the osteotomy tips offer the possibility to obtain in a fast way a flat surface of the crestal bone. Now you can see. We set up the device and then we could start. You can see that making this maneuver, pulling a little bit, I touch and then I pull, I touch and then I pull, I'm obtaining a flat surface of the bone in a few seconds. Okay, now I'm finished. Okay, now I'm measuring again. You can see we have 3. Is it too narrow? I need to go deeper a little bit, to enlarge a little bit. Okay, here we are. I measure. It's very narrow. It's very, very narrow. Because it's less than 4 millimeter. Okay. Now the last check. I measure is always thinner than 4 millimeter, but I try to do in any way, because usually the perforation technique must be done when the width of the ridge is 4 millimeters, because the implant thickness is 1.8, so we need to maintain at least 1 millimeter buccally and lingually. So now, the most important thing is to establish the axis of the preparation. And to do that, we change the tips and we start to use the tips of the REX implant kit. You can see we have W1, 2, 3, and 4, and the 4H. Using this tip, we prepare the implant side perfectly. The first tip is the W1. The W1, as you can see, is a conic shaped tip that has a very thin, in this area, is a 0.5 and is a 1.8 here. So now try to imagine to be in a patient. You raise a huge flap and you see the buccal and the lingual side. And then you have to establish the right position of your implant site. And to stay in the medium of the ridge is necessary, okay, to make the first osteotomy. The first osteotomy must be done gently, pushing a little bit, and then to engage the largest part of the tip with 1.8 millimeter diameter. Now you can see that we have performed a right hole. Now, using the pin indicator, we are going to see if the axis of our implant is fine or not. The axis looks fine. A little bit angulation, so I need to correct it. And to correct it is very easy because in 2 seconds I correct the axis. Now it's perfect. Okay. Now another important consideration is to establish the distance compared to the other implants. So now we have to do some math. Our implant dimension, measured distally, is a 5 millimeter. So we need to maintain at least one space of 3.5 millimeter in between. So it means that the distance between the axis of this implant compared to the other is around 9 millimeter. 9 millimeter is better than 8.5. So at 9 millimeter, I make another hole, maintaining the same parallelism with the previous one. So, and then it's necessary to go deeper in order to enlarge to 1.8 millimeter. This hole is fundamental when we install the implant because in this part we optimize the implant positioning. I'll show you in the end. So now I change using another pin. I put another pin and I check it three-dimensionally. I see that this pin is too buccal. So I orient them a little bit and I correct it immediately. Done. Now it looks perfect. In order to achieve a very fast learning curve in a practical hands-on like this one, I suggest to install 3 implants because with the first one everything looks too strange. With the second a little bit more familiar, and with the third finally you could obtain the goal. So now, measuring other 9 millimeter, I make another osteotomy in this area. If you try to imagine to be in the molar area, maybe you can stay a little bit distant, maybe also 10 millimeters, because in order to make a prosthesis, a crown like a molar and not premolar. Okay? This procedure must be done gently, without going rushing, without pushing too much. Okay? Now, the final check. I'm looking three-dimensionally. In the mouth, we are working with a mirror, of course. Okay. Now, if we remove now, you can see the three holes. If you remove, you can see the three holes. If they are in the center of the crest. Okay. Now, it's necessary to make easy the preparation, to make one hole medially and one hole distally. This is a facsimile of the implant, and this is 5 millimeters. So, at the beginning, just in the hands-on, not during the surgery, of course, you could establish to make one hole medially and one hole distally too. We want to achieve, to obtain one osteotomy that must be at least 6 millimeters. Why 6 millimeters if the implant is 5? Because the final tips are enlarging the preparation but not are able to increase the distal dimension. Okay? Now, we don't have the suction. Now you can see they have done the first dimension of the first implant. Then now I establish the second one. Okay. It's better to maintain one pin inside in order to maintain the parallelism, of course. This way. And to go deep. Okay. And now the final one. It's very important to avoid to engage the lingual cortical bone. That makes the preparation a little bit more difficult. Okay, now we have done the first implant, the first stage of the protocol, the pilot osteotomy. Now we are going to do the horizontal osteotomy. To do that now we are changing the W1 with the W2. Now I show you the characteristics of the W2. The W2 is a saw with the teeth that are cutting the bone, and then we have some laser mark at 9, 11, 13 and 15 millimeters. Usually in the hands-on we are using 11 length of implant length because it's the most common length used. So to the second laser mark here. Okay? Now it's very important to maintain the same buccolingual direction, the same axis, even with the osteotomy. And the osteotomy is done in order to make in contact the hole made with the W1 in this way. It's a very easy maneuver. You have to enter, to maintain in the same direction, and to go deep. Usually, if there is, now try to imagine to be in the patient, of course, if you don't have any anatomical limits, it's better to go a little bit deeper compared the laser mark. I can see because I have no lights. Okay. It's here, maybe I'm going a little bit deeper. Okay, maybe 12 is fine. Okay, this is done. Now I do the same here. I'm combining the holes, and then I'm going deep. I'm maintaining the same vasolingual direction, because if I modify it, maybe I engage the lingual cortical bone. This is 11 millimeter. Then I have to go a little bit deeper. Okay, it's done. Perfect. So the last one. This maneuver must be done medial-distally, gently, step by step, going down step by step, not pushing directly from the cortical to the apex direction. A little bit deeper than 11. Okay, now I'm in 12. Perfect. So at this stage, it's very important that usually it's not the preparation inside is not supersized, because we have many spikes. In order to finish in the preparation, in order to remove the spike, we change the W2 with the W3. And the W3, I show you the tips characteristics, is exactly the same shape, but instead to have the cutting teeth, we have a diamond cut surface. What is the, in which way we have to work with this tip? We have to remove the spikes inside, and to do that we have to follow the contour of the preparation, vertical, apical, and vertical again, in this way. Look, I enter in a vertical distal area, and I'm doing this maneuver, going vertically and deeper, and then I move in the end of the preparation in order to smoothing the bone inside, and then vertical to come out. Now it's perfect. Then I check immediately if my preparation is well done, dampness, overhaul in the corner. I'm using the facsimile to do that. I put my facsimile, I'm looking the laser mark, and this is perfect. Okay, so I can go ahead, and I'm doing the same in the following implant side. Vertical, horizontal in the apex, and vertical again. Overlapping the corner is the most important thing. Overhaul if you have a cortical bone inside. And then, using the facsimile, I check again. Well done. So now I can finish the finishing vertical, only the same procedure. The protocol is very easy to follow because it's only step by step. You can control for each step of the preparation perfectly. Overlapping the corner in this corner, vertical again here, and now it's done. And now we check. At this time, our preparation is finished. When we check with the first field gauge, we have to see if the length of medial-distal of our preparation is too short, is risky, because when we enlarge it, the medial-distal dimension is reduced for the shape of the following insert that I show you now. Okay? Now we have to do the differential implant site preparation. What does it mean? That the cortical bone, the crestal cortical bone, is thicker compared to the cancellous bone, the underlying cancellous bone. For this reason, we need to use another tips. We need to use these tips called W4. You can see the cross section surface, very effective. If you see the section is triangular in the apical part and rectangular here, but this medial-distal part doesn't cut at all. For this reason, if your initial osteotomy is too short, when you finish to use this one, become shorter than this. I'll show you. Unfortunately, to prepare the implant site preparation in a car rib is more difficult compared in the patient crystal bone. There is also an article in literature that making evidence these difficulties in the hands-on. But to me, it's very important to do the hands-on because we have the time to check each detail, to come back and to repeat, and soon the protocol is well done. Now you can see that this thickness is 1.60 millimeter. Until now the preparation is 0.7. So we have to enlarge the preparation. But what I suggest to you is to see the axis of the preparation and to maintain the same axis even during the differential implant site preparation. That means to enlarge just the cortical. This maneuver is very easy because usually the cortical bone is just 3 millimeters. So it's necessary just entering with this tip for 3 millimeters. Now you can see that this tip has a different laser mark that I showed you in the diagram before. The first one is corresponding just to the shoulder of the implant. Always you have to go down. If the bone is without any cortical bone, it's sufficient. When we have cortical bone here, like in this case 2 millimeters, it's very important to diagnose the cancellous bone density. To do that, obviously, we have to do presurgically, looking the CT, CB cross-section images to establish if the cancellous density is low density, medium density, or high density. When it's a high density, or when you work even in a cortical bone, it's necessary to go deep with these tips to the second line, medium density, to the third line, high density. In this case, I have some cortical bone, lingual bone, so I have to go a little bit deeper. So now I'm preparing the body of the implant undersizing. The body of the implant undersizing is the most important part because we want to achieve the primary stability exactly in this part. In order to establish surgically if this maneuver is well done or not, we have another depth gauge. This depth gauge measures exactly if the preparation is well done or not for the body of the implant. In this case, I see that it is exactly perfect. So I have to do the same in the following implant. But remember, before to make the differential implant site preparation of the cortical bone, you have to see the axis of the initial preparation. Following this axis, now it's possible to enlarge, to prepare just the cortical. And then, unfortunately, it's easy in the patient because in the presurgical study we can do a very precise diagnosis. In this way, we have just to imagine to do that, to forecasting to do that. Okay? Also in this case now I'm using the depth gauge for the W4, and it doesn't arrive completely. I have to go a little bit deeper. Overall, in the corner, remember the corner. Okay, now I check again. As now it's perfect. So now I have to finish I have to check the axis. I have to check the axis with the first feed gauge, and then I'm going in this way. Remember that you have to do a very gentle movement, measure distally, but remember to overlap in the corner. Okay? At the beginning, this surgical protocol looks difficult, but trust in me, it's very easy and very fast. Now we are spending time because this is educational. You can see that it's too difficult to engage completely. a half millimeter more is better. So I re-enter gently. Because I'm engaging the cortical bone inside, I recognize perfectly. If you don't do that, the implant doesn't enter. So now it's very important to check again. Now it's done. Perfect. So now, using the same depth gauge, but upside down, in this side, we have the final preparation just of the cortical bone. And you can see that is not enough. For this reason, we have to change the W4 with the W4H, that is the last tip, to prepare just the initial part, the crestal coronal cortical bone. This is the most mineralized, the most atrophic part of our implant side. For this reason, we need to undersize close to zero in order to avoid to make compression with the implant in this so delicate area. So we have to enlarge it with the W4H just in the initial part. Don't go too deep, because if you go too deep you lose the primary stability of the body of the implant. Okay, now the preparation is done. Now you can see the preparation characteristics. What we can observe, that even if this ridge was so thin, we were able to maintain more than 1.5 millimeters lingually and more than 1 buccally in each side. So now I like to show you the result of this surgery, because even in a ridge very thin, 4 millimeter width, we were able to make a very thin perforation technique, because we remove just 1.8 millimeter. And if you see, it's possible to preserve more than 1.5 millimeter lingually and almost a little bit less buccally. And this is very important. Why? Because all the vascular supply move exactly in this area. If you reduce this bone volume in this area, unfortunately, you have one implant distance. So now we fixed again our block, and then we are ready to install the implant inside. In order to install the implant, we have these implants, of course, are facsimile, using many times, so they are not so. Also without a rough surface, is a machine surface. Okay. Now you can see that the implant shape is a wedge, so it's a very convenient. It's very convenient even the rectangular section, because it has the same morphology of the ridge. So now we put the implant in this way, and usually it's possible to install in a passive way until the shoulder. Then we remove the tube knobs, and at this time we have to change the technology using a implant placement device technology. This technology produces some impaction, and now I'm starting to do that with the low power level in order to check the bone. And then I increase the force. I increase the force. And then suction. I make the final strong stop. The implant is installed. Now we have to install another implant. We are doing the same procedure. Okay. And now we remove the tube knobs using the striker. top. And now we have to install the final implants. Okay? I reduce the force. Usually I check the force just for the first implant, and then I don't check anymore with the others. I'm going with the strong force, okay? The strongest one. Okay. Now we check the implants position, and now we have to screw out with the screwdriver. We remove the mounting, and then we check the ISQ, the implant stability. Usually the mounting are very well positioned and pre-torqued by the industry, not in the hands-on, because from one course to the other they are not so well prepared. Okay? Now, okay, now please, okay, we use the hostile technology to establish if the primary stability is good enough or not. Usually, before to measure, we measure buccolingually and usually and linguobacally. This value is always down because the bone is thin and the implant is thin. Mesiodistally and distal mesially is a little bit higher. Usually the average is around 60 in this direction, around 70 in this direction. Let's to see in this case the okay. Now I measure distal mesially is 70. Very strange, 70 also in this case. Usually it's less than this, but not so bad. Okay, not so bad. It's better. La plastichetta. No, the way it is. Okay, I change and then I engage the other in a proper way. Now I'm measuring the last one. This is 69, 70 is fine. It's fine. Now, buccolingually, only the same. Okay, 62. This is fine. Now, if you see the surgical result, this looks very nice, because now you can see that the implant positioning is correct, because the shoulder of the implant is a ½ millimeter under bone level. You can see here a little bit. But the neck of the implant is not engaged, possible to see, is not engaged into the lateral wall. Because if you are going to dip with the tissue level implant, you risk to create compression here, the most delicate area. For this reason, we have to position the implant in this way. In this way, usually the tissue level implant is around 2 millimeters, and then you have the prosthetic connection. Usually the thickness of the soft tissue is 3 millimeter. But in a dentulous ridge, very thin, the thickness it could be less than this. For this reason, it's necessary to suture it a little bit coronally. Okay? Now it's sufficient to screw in the healing abutment, to suture, in the patient of course, and then it's done. Okay. Now we have finished the hands-on that is necessary in order to start to using this kind of implant, because it's a different surgical protocol compared to twist-drill implant, of course. And if you have any question, please, it's a pleasure for me to try to answer.